Thank you very much, Tim, for getting us started so very, very nicely. I'm going to... Okay. As I said, I want to keep my introduction of all the speakers short, but I will make one or two observations of Dr. Sigal that I think are pertinent and tell you something about the individual. The first is something that was put in the small blurb that went with the information. Dr. Sigal has headed up the group that put together the guidelines for exercise for the Canadian Diabetes Association, exercise guidelines, and he's going to share that with you. And that tells you, for example, how fastidious and how careful he is, because normally the person that we put in charge of those kinds of things, you would expect to be someone who pays attention for detail. I had the privilege of sitting with Ron on a CDA grant evaluation committee a few years back, and I was sitting right beside Ron, and it was Ron's turn to evaluate a grant, and I'm gathering that Ron at the time didn't like the submission very much, because the grant, the review that Ron did of the grant was actually longer than the grant itself. I couldn't believe how fastidious this individual was, the care for detail and the concern for accuracy. That's the kind of person you want leading up a guidelines team, and Ron, we look forward to your observations with respect to the physical activity guidelines for Canadians for anybody with diabetes. Dr. Sigal.
Thank you. I'll start by saying that there's some people in the audience who know me, and if anyone who's been to my office would never say I was fastidious. So I'd like to also acknowledge the other members of the working group for the CDA in developing the clinical practice guidelines for physical activity for 2008, the most recent cycle. And they include Dr. Pradum, who's in this room, as well as the others listed on this slide. Now, a few points about the CDA guidelines. They're different from the guidelines that Dr. Haskell will present later, and even different from the American guidelines, in the sense that there's a major push to make them concise and simple. Now, the CDA guidelines are not just on physical activity. They're really meant to cover all aspects of diabetes care. They're meant to be evidence-based, drawing from the best available published evidence, and not from anything that hasn't been peer-reviewed and published in a full manuscript form. And at the same time, simple and practical. Now, most of you will know what this is, but for the few who don't work much with diabetes, I wanted to define what hemoglobin A1C is, because it's an important variable in diabetes. It's abbreviated, first of all, as either A1C or hemoglobin A1C, as you see it written there. And essentially it's a reflection of blood glucose control over the past 2 to 3 months. It's the percentage of hemoglobin that's glycated. And for someone who doesn't have diabetes, this percentage will be between 4 and 6%, usually around 5%. And in people with diabetes, we usually don't strive for absolute perfection, but we usually try to get it down to around 7% or a bit lower if it can be done safely. And the importance of this number is that in epidemiological studies, a 1% absolute change, that is going, let's say, from 9% to 8% or 8% to 7%, was associated with a 15 or 20% decrease in cardiovascular risk and a 25 to 40% decrease in the risk of microvascular disease, like eye disease or kidney disease or neurological disease. So in the event that I run out of time, I figured I'd start with the conclusions, actually present what the recommendations are, and then if there's time for me to say anything else, I'll say it. So the first recommendation, and there are only three of them really, people with diabetes should accumulate a minimum of 150 minutes of moderate to vigorous intensity aerobic exercise each week, spread over at least 3 days of the week. Notice not 4, not necessarily 5, although there's nothing wrong with doing that, but at least 3. And the key point is with no more than 2 consecutive days without exercise. And that's because the effect of exercise on insulin sensitivity, or aerobic exercise, tends to be in the 48-hour range, usually not more than that unless it's very prolonged exercise. For resistance exercise, people with diabetes, including elderly people, should also be encouraged to perform resistance exercise 3 times a week. Now, this is in contrast to what the American Diabetes Association said until a few years ago, which was that this type of exercise was completely inappropriate for someone who either had long-standing diabetes or was middle-aged or older. So in other words, for almost all people with diabetes, it would be completely inappropriate, and that's up till about 5 years ago. And initial instruction and periodic supervision by an exercise specialist is recommended. And we say this partly because it's common sense. There'd be less risk of injury, presumably. Presumably there'd be better progression. And also because all of the trials on which our evidence is based used supervised exercise. I'm not aware of any trials where someone was just told, go and purchase weights and exercise and let's see how you do. And then this is actually the recommendation that's probably the least evidence-based. And at the same time, I've had a number of people mad at me because of this recommendation. So as you'll see, it says an exercise ECG stress test should be considered for previously sedentary individuals with diabetes at high risk for cardiovascular disease who wish to undertake a program more vigorous than brisk walking. Now, some people were saying, well, you're trying to start all kinds of people getting stress tests, but actually this represents a considerable narrowing compared to the previous recommendations. Before this, they were saying essentially everybody with diabetes, if they're over age 35 or if they're over age 25 with even one risk factor, had to have a stress test before embarking on any kind of exercise program, even a walking program. So this is a considerable narrowing, not a broadening. And why? Why would one have any kind of recommendation on this issue? It's largely driven by concerns regarding silent cardiac ischemia. And before I go any further, I'd like to say that there's certainly a value in doing a maximal exercise test on anybody, a person with or without diabetes, as I'm sure Dr. Blair will be talking about the kinds of very valuable prognostic information. But that's not what I'm discussing here. The reason is, for why we think of stress tests in people with diabetes, primarily is concerning silent cardiac ischemia. At least that's the thinking behind it historically. And it's not an absent problem. Now, the prevalence of silent ischemia, in other words, people have coronary, like narrowing of the coronary arteries, which is causing decreased blood flow to the heart, but they don't know it because they don't feel the symptoms for it. And it's in some studies they say it's 4% of people with diabetes, and some they say 75%. And of course, it depends